Welcome to the Therapeutic Management of IBD, the Paradigm Shift to Personalized Care Symposium. This section of the webcast is titled IBD Pathogenesis, Personalizing Targets, presented by Laurel Riley. Once you have completed this activity, you will be able to assess the mechanisms of disease involved in the pathogenesis of IBD. I hope you enjoy the presentation.
Thank you, Michelle. Good evening. Over my next 15 to 20 minutes, my goals are to be to update you and give you information on the current pathogenesis, what we know about what causes inflammatory bowel disease. I'm also going to be talking about how biologics are used to manage these. And then in the end, we're going to determine how we can use this information to personalize treatment for patients with moderate to severe disease. Inflammatory bowel disease, it really ends up being two subtypes that you mostly know about, ulcerative colitis as well as Crohn's disease, but there's also a small percentage of people, approximately 10 to 15%, that get diagnosed as what we call indeterminate colitis. And this term actually came from back when the pathologists were evaluating colectomy specimens on patients that had surgery. And what they were coming up with is they were unable to determine that it really didn't look like Crohn's, it really didn't look like ulcerative colitis, and was termed indeterminate colitis. But usually what we find out is that somewhere in the follow-up that they tend to gravitate to one or the other. And so now this is a term that's been used in clinical practice now by our physicians when they're doing colonoscopies and biopsies. So ulcerative colitis is a disease of just the colon. It affects the mucosa only of the colon. And then the description is based on the area where the inflammation is. So say if it's only in the rectum, that's proctitis, and then we go into proctosigmoiditis, left-sided, and then as it advances and goes through the entire colon is when it's termed pancolitis. Colonoscopy is key to making the diagnosis so that we're able to get biopsies of these specimens, and that what we're looking at is the normal colon here is showing you where it's got all the landmarks and that it's got all of this good blood supply. And when we're looking at ulcerative colitis, we're looking at edema, we're looking at ulcers, we're looking at friability, we're looking at bleeding, and that they've lost those hallmark of what you see with the normal colonoscopy. So the colon evaluation is important, and then it's because of those findings that the signs and symptoms occur. Bloody diarrhea is the hallmark of ulcerative colitis. So the patient will report rectal bleeding. They've got abdominal pain. It's usually left-sided abdominal pain when the disease is confined to that part of the abdomen. And as the patient gets sicker, they're having more diarrhea, they're having more bleeding, they're going to have more systemic complaints, anorexia, nausea, vomiting because of the swelling going on inside the colon. They're going to have weight loss because the body is unable to absorb any of the nutrients because it's so ill. They're going to have fever from their infection. They're going to be fatigued, maybe perhaps from the anemia because of the bleeding. Crohn's disease. So although the two may have similar presentation, signs, and symptoms, they're actually two different diseases. Crohn's disease is mostly a disease of the small bowel where the terminal ileum comes in contact with the large bowel, the cecum. And it's here where the patient will develop a lot of fibrosis, scar tissue, and then actual stricturing disease. But to understand this inflammatory bowel disease can occur anywhere from the mouth to the anus. And so here's some more of the other hallmark. Granulomas is when the body is identifying that you've got this this foreign object there and it's trying to wall it off and get rid of it. The strictures, as I talked about. Now, with Crohn's disease, there's going to be transmural, meaning it's going to go deeper than the mucosa, and it actually will burrow itself from one organ to the other. This is what we call fistulas, fissures down in the anal area. But the other hallmark of Crohn's disease are what we call these skip lesions or cobblestoning, where they go from having a normal patch in the area to an abnormal patch. And this is what I'm showing. This would be perhaps what you may have even seen yourself, the terminal ileum look-see, where you're seeing the fibrotic area where it's become scarred. And these patients are going to present with obstructive symptoms, that they're going to have the bloating, the nausea, and vomiting because the outlet is becoming compromised. And again, some of the same signs and symptoms. Abdominal pain and cramping is going to be because you've got swelling in the area, and this is going to cause spasms. There may be some blood in the stool if there is disease more towards the rectum. Again, you're going to see more systemic the sicker the patient is. And understand that, if these patients, and it's not unusual that these patients end up with surgeries, removing parts of their small bowel or maybe even parts of their stomach, areas where certain nutrients are absorbed, specifically B12 and iron, so you can see deficiencies there. And again, when they've got these fistulas and fissures, there's going to be perianal disease. So what causes inflammatory bowel disease? Well, it's an ongoing look-see by everybody. When I sit down with my patients and have to go through with this, it's a combination of being genetically predisposed, meaning if there's a if there's a relative, you have a 1 in 5 chance of having either Crohn's disease or ulcerative colitis. And then what you have is some sort of mucosal immune system, that there's a deficiency in the immune system. In combination with environmental triggers. Basically, the way I talk my patients is the sun and the moon and the stars all came together and have created this inflammatory process. Over the last 10 years, we've located about 163 genes responsible, and that it's their change in regulatory that is causing the inflammatory process. And what we figured out is, with all of these genes, they all have different roles. Some of them are protective. Some of them help us tolerate the disease. Some are responsible for lymphocytic activation. Some of them have barrier functions. And this is just showing you that what we end up having is this perpetuating problem where we have this chronic relapsing inflammatory disease, that we lose the homeostasis. That's what's going on inside of our body between the immune system and then the gut microbiota. And then you've got this disruption of the epithelial barrier that's supposed to protect us from having inflammation. And all of this contributes as well as perpetuates the ongoing inflammatory bowel disease. So here's the environmental triggers, cause abnormal immune response. There are studies that stress can contribute to what's going on there. There's different drugs, such as nonsteroidal anti-inflammatory drugs. Antibiotics are on the list. Infections, if people had multiple infections as a young child or a young adult. Antibiotics is on the list. Vitamin D deficiency is on the list. They looked at people in Canada who spend a lot of time in the inside during the winter. Different dietary things, that there's some animal fats that may be contributing to some of the symptoms. Fiber becomes part of that. And one of the things that's been most studied and actually replicated is smoking. And it's different between the two diseases. For Crohn's disease, it actually will make the disease worse and is responsible for relapses and causing more severity. Whereas for unclear reasons, ulcerative colitis, it can be protective. They're not quite sure if it's the nicotine part of it or if it's another part. And so what we've got here is a summation of events accumulating, again, as I said, to the intestinal inflammation. We've got the genetic predisposition, we've got the genetic modification, and then we've got the changes in the gut microflora, and then the different environmental factors that we just went over, causing the inflammatory process. So current treatments, it's really important that you need to know where the disease is and how severe the disease is in order to choose the treatment. Aminosalicylates are 5-ASA products. These are topical anti-inflammatories. As I explained it to my patients, it's like putting sunscreen on. And depending on where the disease is, so if they have the disease more distally, you're able to use things such as suppositories, foams, and enemas. But as the disease progresses and moves further, they have to include oral 5-ASAs. And what's always been difficult, these are the things like Pentasia, Colazol, Azicol. This was a high pill burden. These were 2 and 3 pills that they had to take 3 and 4 times a day. And compliance was a huge issue. Thank God now we have things like Lialda and Apriso, which with their formulation are designed to be taken once a day and coat the colon. Corticosteroids, understand that the body has hormones in them naturally, and the way corticosteroids work is that they work to block this inflammatory process that is going on through the hormones. It's used for a lot of anti-inflammatory diseases, rheumatoid arthritis and asthma as well, but it's not without its side effects. Immune modulators are exactly what the word sounds like. It helps regulate the immune system. It's part of trying to get the process to be normalized by reducing the function of the body's immune response. But although the immune system is important for fighting infections, the immune system cells sometimes mistakenly attack the body's own tissues. The way I explain it to my patients is this is an autoimmune disease. Same way with thyroid disease, rheumatoid arthritis, and so this is trying to put things back on track. Immune modulators are things such as azathioprine, 6-MP, Imuran, methotrexate. They take some time to work, and so other medicines, perhaps steroids, would be used in the meantime. Antibiotics, they're used to decrease the concentrations of bacteria inside the gut lumen. Specifically, we use Flagyl and Cipro, and it's more common to be used with people with fistulizing disease. And there's more information coming out to use Xifaxan for pouchitis associated with those patients. And we also use probiotics. Probiotics are the good bacteria that we want to go in and help raise the good bacteria inside this gut that is full of bad bacteria. And then there's the biologics. The tumor necrotic factor is inside of us, and the levels are elevated in the serum, stool, and intestinal tissues of patients with inflammatory bowel disease. And basically what biologics are anti-TNFs, which mean they block that activity and therefore blocking inflammation. The one that we know about, infliximab, Remicade, came out in 1998. It's the one we've known the longest and the one we've got the most experience with. It's an infusion that can be done in an office or a hospital situation. And it's used for both Crohn's and ulcerative colitis. And then we have injectables, adalimumab, also known as Humira, certolizumab, Cimzia, and golizumab, which is Symphony, are all injectables that the patients can be taught to give themselves at home. Some are, remember, Remicade is part chimeric, which is a mouse molecule, and so could be a reason for the patients to develop antibodies and lose response, whereas the rest of them have all been humanized. And this is kind of to give you an idea, YMCA, of how the molecules are made. Infliximab there with the yellow tips at the end of our shoulders here is the chimeric part, and this is how they attach to block the inflammation. The other are the all humanized, but look at the certolizumab. Certolizumab has pegylation on it, and what that does is keep the medicine in your system longer so that it's working longer. And now the new kids on the block are the biologics, the alpha integrin inhibitors. These are traffic controllers. Again, back looking at that inflammatory response, there's several things that are causing inflammation. And now what we're looking at is to block the leukocytes from infiltrating the gut. These are adhesion molecules. Vedolizumab, which is in TVO, is an infusion for both Crohn's disease and ulcerative colitis, given as an infusion almost in the same regards as Remicade, where it's done as an injection at 0, 2, and 6 weeks, and then once every 8 weeks thereafter. It's a 300 milligram infusion that only has to be infused over 30 minutes. They like that. Natalizumab, indicated for Crohn's disease only and given as an infusion monthly. Both of these are, as all of these are set up to be specific for the inflammatory. Natalizumab, unfortunately, is able to attack inflammation in other parts of the body, and you may have heard of some concerns about the cerebral spinal fluid and an infection, whereas Entyvio is just gut specific. And this is kind of showing you how they attach to do that blocking setup. So now we've gone through the plethora of different things that set up the inflammatory process, and then how can we rearrange that through our treatments with these patients, whether it be with steroids, antibiotics, biologics, probiotics. Fecal transplant's the new one on the block there, though it's been approved for C. difficile infection, it's really being studied in a lot more. Immune stimulation, this is the worm. This all has to do with trying to get back to the hypothesis that we've become a sterile population, that before modern times, it wasn't, most children and adults were known to have worms in their system. So this is going back to perhaps that's how we have to change things. And then the different other triggers that I spoke at, specifically nonsteroidal anti-inflammatory drugs, smoking, exercise, stress. Actually, another piece in here too that I don't think we talk enough about with our patients in any disease is the sleep they get. You know, I explain to my patients that the body needs 7 to 8 hours a night to regenerate. And if you're missing an hour a night, add that up times 7, you've missed a whole night of sleep. I hated working third shift. So what do we tell our patients with inflammatory bowel disease regarding all of this? Strong recommendations that they need to avoid the nonsteroidal anti-inflammatory drugs, that they need to quit smoking. All patients need to quit smoking. Adhere to medications. This is a tough one. And this was one of the ones, when I first came into practice, I started with giving infusions in the office. And I would go through asking them their questions of their medications. You still taking your blood pressure medicine? You still taking your Colazol? And they go, yep, yep, yep. It took me a while before I realized that yep maybe wasn't a positive, and that the next time when I started interviewing these patients, I'd look at them, so how many times did you miss the Colazol this week? You didn't get that third dose in, did you? They'd look at you like, you know, really? Yeah. And it is. I mean, how many, I mean, my hand will not write a prescription for 3 times a day or 4 times a day. That's set up for failure. So compliance is huge. And that's probably where I enjoy doing the infusions in the office, because I'm able to have that compliance with the patients. Modest recommendations, the vitamin D levels I spoke of. Exercise is important for all of us as well. Here's the sleep piece. Reducing stress. Okay, let me know how you make out on that one. Meet with a dietitian, nutrition. This is huge because a lot of these, and I think the thing we have to understand is this is a disease of young people. And Maureen's going to get into some more of that here, but these people may be malnourished from the get-go when we're seeing them. We need to screen them for depression. This is a chronic disease, and that's probably the hardest thing to get into this group, is for them to understand that they've got a disease that's not going to go away, and it's going to come back, and it may get worse if they're not compliant with their medications. Thank you.